Good afternoon, esteemed colleagues, guests, and citizens of our incredible India. I am Professor Sanjay Dhir, Associate Professor and Chairperson of the Strategic Management Area at the Department of Management Studies, IT Delhi. It is my distinct honor today to welcome you all to this QEIE dialogue. Today, we gather to mark a significant milestone in our nation's public health journey. Our country has successfully distributed over 2 billion doses of its COVID vaccination program, a testament to the resilience, determination, and unity of our people and our health systems. And this achievement is not just a number, it's a symbol of hope, a beacon of progress, and a testament to the power of collective action. Furthermore, there is a renewed focus on the preventive healthcare in India, projected to reach approximately $200 billion by 2025. However, we also face significant challenges. Mental health, for instance, has emerged as a major concern, with 30% of the Indians identifying it as the biggest health problem in the country. Our success currently in this large-scale public health initiative is built on four key E pillars. The first E is efficiency of the health systems. The second E is evidence-based actions. The third E is empowerment of communities. And the fourth E is equitable access. As we navigate the challenges of the pandemic currently, we are also recognizing the importance of the fifth E pillar, that is empathy, particularly in the light of pandemic that affected marginalized population in terms of their living conditions and socioeconomic security. So in today's dialogue, we'll delve into these e-pillars. We have invited esteemed speakers who will share their personal anecdotes, propose actionable recommendations, and consider the wider audience. Their insights will not only shed light on our current situation, but also guide us towards a future where health is a right, not a privilege, and where every citizen has access to the care they need. I'm pleased to introduce Dr. Shankar Ghosh, a very renowned personality in public health, who will provide a summary of each conversation we are having today, and Dr. Deepika Sharma, who will moderate all our discussions with the speakers. Our speakers for the e-dialogue are Dr. Aqsa Shaikh, Dr. Manohar Agnani, Professor Satendra Singh, and Dr. Benazir Patil, each bringing their unique perspective and expertise to the table. As we embark on this dialogue, I encourage each one of you to listen, engage, and reflect. This conversation is not just for us, but for you, the citizens of our incredible India. Your participation, your voice, your action are crucial in shaping the future of public health in our country. Once again, I extend a warm welcome to all of you, and let us engage in this dialogue with open minds and a shared commitment to improve the health and well-being of our all the citizens. Thank you so much. Over to you.
So, welcome everybody to the dialogue on quality, equity, inclusiveness in urban healthcare delivery. Joining us today is Dr. Aqsa Shaikh. She is an associate professor of community medicine and nodal officer for the COVID vaccination center at the Hamdard Institute of Medical Sciences and Research, Jamia Hamdard, Delhi. She is one of the India's first transgender doctors and a proud advocate for transgender rights. She is also involved in the I Hear initiative at Sangat, India, which focuses on including the transgender and disability communities in the healthcare sector. She is the founder and director of the Human Solidarity Foundation and a vocal advocate for rights-based gender justice for transgender people, people with disabilities, and people with mental illness. Dr. Sheikh has been recognized for her work in mental health, receiving the Youth Ki Awaz Award. Dr. Sheikh is interested in medical ethics, the humanities, and medical education technology. Dr. Sheikh, we would like to congratulate you first on managing one of the busiest urban COVID vaccination centers at Hamdard Institute of Medical Sciences and Research, Community Medicine Department. Kindly reflect on the planning, management, and personal satisfaction of the experience. Let us begin by asking you about some of the unique features you have adopted in managing the center and other reflections on making this center user friendly for marginalized population. Also, please highlight any awareness campaign activities that you have undertook for the center.
Thanks, Deepika, for having me for this very vital conversation on my experience around managing a COVID-19 vaccination center in Delhi. So I remember it was 16th of January 2021 when we first started the COVID-19 vaccination program in India and also in Delhi on the same date. And our center was also opened on the same date. We need to kind of go back and understand the situation in which vaccination was launched in India. We were in the middle of the pandemic. People were dying. We had no cure available. And at that point of time, the only hope that we received was getting an effective COVID-19 vaccination. And especially in the first phase, if you remember, it was started for the healthcare providers. And at that point of time, it really came as a glimmer of hope for those who are trying to save lives of others, that finally we may have something that can protect us from this virus that we really don't understand. It was in that environment that the vaccination center was launched. But at the same time, there was also, I would say, concerns about the effectiveness and the safety of the vaccine by the healthcare workers, because it was a new antigen which was being launched. Some of the vaccines at that point of time were not fully approved for use. They were only allowed for use in the trial conditions as an emergency provision. And therefore, there were a lot of healthcare workers who had concerns about taking vaccination, and the government had literally mandated that the healthcare workers first take the vaccines to build the trust and confidence amongst the masses. So it was in that scenario that the vaccination was launched, and I was very blessed to get the opportunity to manage this vaccination center, not just as a community medicine person, but also as a transgender person. I took it as an opportunity to ensure that this service is made a quality service and a very inclusive service. And when it comes to quality and making a service inclusive, I think one very important aspect is to ensure that it is technically correct, that it is scientifically valid. So the first thing that we did was to ensure that we had a safety net cast wide. We had developed an ICU bed as an AEFI facility, adverse events following immunization, within the vaccination center. We ensured that the vaccination center was not in the hospital but in the college building, because in the same hospital building there were COVID-19 patients and many people were afraid of going to the hospital building for getting the vaccination. We ensured that the protocol, for example, of allowing people to be observed for 30 minutes post vaccination is followed for everyone, even if they happen to be the dean of the hospital and extremely busy. So these important steps in the quality assurance were followed, so that we do not compromise on the quality and the medical aspects. I remember we had very interesting drills on how to manage AEFI, and we undertook certain provisions to ensure that people were confident that if I take this vaccine and if anything happens to me, then I will be in good hands. So we ensured that we had a dedicated lift for the patients and for taking AEFI. Ramps were opened up. There was a dedicated ambulance, and the path for the ambulance to reach the hospital was always kept open and clear. So these important measures were done so that first of all our healthcare workers get confidence in not just the vaccine but also in the process of vaccination and managing the adverse events following immunization. Once all those things were in place, then at that point of time there was a lot of environment of fear, apprehension, uncertainty, and we wanted this vaccination process to be a celebration, to be a very joyful experience, of celebrating the human innovation, celebrating that we are finally getting some breakthrough in our struggle against COVID-19. And therefore the entire vaccination center, right from the entry, the waiting room, the vaccination area, and then the post-vaccination observation area, was decorated in a way that it celebrated the process of vaccination, because people had to spend a couple of hours from the entry to the exit, and we wanted that experience to be joyful, peaceful. People were bringing their children to the vaccination center. They were coming with elderly who were also wheelchair users, and we wanted that it should be a comfortable experience. That was the first time I remember when we ensured that there was a unisex toilet in the university, and for a very long period of time that was the only unisex toilet in the university, the first and the only. Ramps were opened up, cleared of all the obstacles. Many times in our infrastructure we do have ramps, but when a person actually wants to use them, there are obstacles around, there are flower pots kept around, and they're not open sometimes. So we ensured that these structures are not just existing, but they were also functional, and special provisions were made for that. We had kept selfie booths. Also videos were on for people to enjoy and relax, because we had seen that there was a lot of anxiety when a person came to take vaccination, and we wanted it to be a very joyful experience.
Right. Very well said, ma'am. And my second context was related to innovation strategies only. And you very well mentioned how you started decorating the areas from where the people were traveling, so that to provide them a very good experience for the vaccinations. So now I would like to draw your attention to more few innovative strategies that urban primary healthcare centers can adopt, particularly around social mobilization and building trust and confidence in the community. These strategies address some common barriers to getting COVID-19 vaccination. These barriers may include structural, behavioral, or informational too. They involve fostering strong relationships and partnerships with trusted organizations and communicating responsibly, which are fundamental to any strategy for establishing trust within the community. So, we would like to hear your thoughts on these innovative strategies and how they might be applicable to your work at the vaccination center. And we would also like to learn about any other innovative approach that you have adopted.
So, when we speak about vaccination process, it's not just about one particular center, and it's a multi-pronged approach to get a person to accept vaccination and to get vaccinated. And especially when we have clients who come from marginalized populations, be they from the transgender and intersex community, whether they are persons with disability, or elderly, or people with mental illnesses, or even women who are pregnant, for example. We have to ensure that the vaccines are acceptable to them. They have trust in the product and they have trust in the process of the vaccination also, and that was something that we had to work on, especially in the initial phase of the vaccination process. So the first thing was, as I mentioned, about the infrastructure and ensuring the infrastructure was accessible, it was friendly, it was comforting to people. But another important issue is, what about those people who have not yet come to the vaccination center? How do we get them to come? Especially speaking of my experience with the transgender community, there were issues of lack of information, or lack of correct information, I would say. There were many questions that were unanswered, like if the vaccination had been tested on transgender people or had it been only tested on cisgender people. Does the vaccine interact with the hormones that a transgender person may be taking? Are there any documentations of adverse events that specifically occur in transgender people? Is it safe to take vaccination during the surgical transition phase, since some of them were about to get operated or had gotten operated, and we had heard about coagulation related adverse events happening? And then there were also questions about the process of vaccination. There are some transgender persons whose legal name may not match with the name that they are currently using. Their legal gender may be different from the gender that they identify with. Then if they come to the vaccination center, they have to register with the COVID app. How do they do that? Will they get their certificate in the old name and old gender, or they can choose the new name and gender? What about the sex being written on the certificate? Will it be written as others? Because a lot of transgender people have problem with the use of the word other, because it otherizes them into something else. And then there were also issues about how they will be treated at the vaccination center, for the queue to reach the vaccination center, while they are waiting in the vaccination center. There were questions about whether the healthcare workers will understand who they are, or will they ask unnecessary questions. Will the guard at the vaccination center, the civil defense volunteers, the nurses, will they be cooperative, respectful, or will they face stigma and discrimination at the vaccination center also? So there were a lot of questions and anxieties that a potential transgender client had, and we try to work over them by asking prominent transgender persons, who have a say in their community, to come and get vaccination, because once they get vaccinated, then they become ambassadors for our vaccination program. And we celebrated that by posting it on Facebook, Instagram, that for example, Abhina has come and taken vaccination. We also did a lot of online programs, especially with the CBOs, and ensuring that the transgender people who do not have access to a lot of scientific information attend this, so that they get proper information, and I would say truthful information. Like for example, saying them that the vaccination is safe, 100% safe, would not be the right answer. So we said that this is the information that we have and this is the information that we don't have. We were very honest in saying that the vaccines were not specifically tested in transgender people or on trans people who are on hormone replacement therapy, but that we expect that the benefits of this vaccination will outdo the risks that we can anticipate. So this clear, honest communication can help building trust in people in vaccination, rather than saying that it's 100% safe, it's 100% effective, and nothing is going to happen. So that was something that was built in the process of the vaccination. I think one very important thing that we did was we made it a very model center for vaccination for queer folks. So there were many people I remember who were not near a hospital, who would travel to like 15-20 kilometers just to come to this vaccination center, because they knew that the nodal officer is a transgender woman herself. And that gave them trust, that I will be respected over there, that I will not be discriminated. And I think that signifies the importance of having the community involved in the process of delivering the vaccine. Rather than looking at them as only recipients of a service, we need to see how the marginalized communities can become the providers of this service, because then that takes the trust to a very high level. And that's what we did with this process. So that was another innovative thing that we did in building the trust. And also we were always hesitant to use the word vaccine hesitancy, because when you say vaccine hesitancy, you are putting the onus on the recipient of the vaccine, that there's everything is perfect, why are you hesitant in taking the vaccine? But rather we always looked at vaccine trust and vaccine acceptance, and honestly looking at what are the barriers because of which people are not able to access vaccination. Like for example, when it came to elderly, we had a lot of demands from elderly that we want home vaccination, that it is just not possible for someone to bring a 90-year-old woman to the vaccination center. Unfortunately, we didn't have permissions to do that, but we tried that if we could take certain measures by which we can ease that process. So I remember our vaccination center was on the 3rd floor, and we were like, if you can just get the person to the ground floor, then our nurse will come to the ground floor, we'll give the vaccination, we'll carry a tablet on which the CoWIN app can be opened and we can do the verification, so that the the journey to the vaccination center can be shortened. We can do observation in the ambulance while they are being seated over there. So these kind of, I would say, going a little extra mile, to ensure that every person gets vaccinated. Because, while we were looking at numbers that, oh, we got 100 people vaccinated, 200 people vaccinated, these numbers often hide the fact that the people who are not getting vaccinated are mostly marginalized. For us, the success story was getting one woman of 90-year-old getting vaccinated rather than 10 able-bodied adults getting vaccinated. So while in vaccination numbers matter, it's also important to ensure that we reach out to the people who otherwise would have been left out of the vaccination process. And I would always say this, that it was a teamwork. We had great support from our administration, from the government authorities at the district level, and also from, I would say, my younger team members, right from nurses to ward boys to the civil defense volunteers who acted as security guards. So it ultimately, I always felt that my role as a nodal officer was also as an HR manager, to ensure that this team does not get fatigued, does not get demotivated, and celebrates things like, oh, we had a 90-year-old one vaccinated, we had a transgender person come to our vaccination center, rather than only looking at numbers of 100, 200 being done.
Very well answered, Dr. Aqsa. As you brought your focus towards marginalized communities, I would like to shift your focus towards the mental illness of these population segments. So, people with disabilities faced unique challenges during the pandemic, as we know, and they included increased isolation, difficulty in assessing the healthcare, and also increased anxiety and depression. Despite the increased need for mental health services, the delivery of mental health care in India remains suboptimal. According to Forbes India Report 23, only 10% of people with mental health issues in India receive treatment. We have been hearing from mental health practitioners that long COVID sequels significantly impact people's mental health. In light of suboptimal mental health awareness and delivery care, what steps could governments, communities, and family members take, particularly for the elderly, those with the disabilities, and the transgender population?
You have raised a very crucial question with reference to the mental health, and especially about the marginalized communities and in the wake of the COVID-19 pandemic. So we need to understand that mental health is something which is a need of everyone. Probably I think everyone at some stage of their life may need a mental health care service. And pandemic or no pandemic, the demand for the mental health services, the need for the mental health care services is huge. Add to that the layer of the pandemic, the layer of the measures that were taken in the pandemic, like nationwide lockdown, working from home, schools being shut for a very long period of time, losing your near and dear ones to COVID-19. All of that had added immense toll to the existing, baseline level of mental health need that we have. And the pandemic also led to a decrease in the provision of mental health care services. I would say also reprioritizing infectious diseases over the NCDs and the mental health diseases. And in such a scenario, when now we speak about marginalized populations who even in the ordinary times do not get access to mental health care services, during pandemic they have an increased need but now lesser supply. And therefore they suffer the most. In fact, one of the research projects that we did at IHER initiative was to look at how the transgender community navigated healthcare during the COVID-19 pandemic and how that had an impact on their mental health care. And our findings from that study was that even before the COVID-19 pandemic, a lot of transgender people found it difficult to access basic healthcare services, like just going to an OPD for fever or cough. And with the pandemic, those basic healthcare services were also not available. And we also know that trans people have a higher need of mental health care services because of the additional stressors that they undergo. And even in the ordinary times, they have a lot of unmet needs of mental health care, and that only increased during the time of the pandemic. And a lot of this increase was also because of the violence that was taking place in their biological families. A lot of queer folks, and especially trans people, do not stay with their biological families, but during the pandemic they were pushed back to the families because they had no choice. They do face a lot of physical, emotional and even sexual violence within their own homes, which also includes conversion therapy to try and change their gender identity and sexual orientation by medical and non-medical means. It also included forced marriages, preventing their access to social media, or just meeting friends and expressing themselves in the form of gender expression of their choice. And all that had a great toll on their mental health. Similarly, when it comes to other communities, be it women, be it persons with disability or elderly, again the magnitude of mental health care needs only increased. But when it comes to the provision side, we had seen that a lot of hospitals had become dedicated COVID-19 hospitals. The psychiatry OPD, which was considered to be not a very essential service, was either shut down or psychiatrists were working from home during that point of time. Some of the psychiatry residents were posted in COVID-19 ICUs and they could not be there in the hospital. And I think it hit us a little later during the second wave, when the healthcare workers now started to suffer from mental health care issues. They were seeing death every day, they were seeing hopelessness, and especially during the time when the oxygen supply was very less in places like Delhi. I remember in my own hospital, I used to speak to the healthcare workers and they would like, I'm feeling so helpless, that all my medical skills are useless if I do not have oxygen supply. They were battling with the dilemma of whose oxygen flow to increase and whose oxygen flow to decrease. They were seeing patients gasping in front of them, but they couldn't increase their flow of oxygen. We were waiting that, okay, the oxygen tank is coming, it's 5 kilometers away, it will reach, but our supply may end. And we have seen healthcare professionals themselves, die of lack of oxygen allegedly. Officially, of course, no one died of lack of oxygen supply. And in that scenario, we had started this service of providing tele-mental healthcare counseling to doctors first, and later on to people who were facing grief because of the people who had passed away. And I remember from those incidents that there were some doctors who had lost multiple family members. There were doctors who wouldn't go back home for weeks. They would stay in the hotels because they didn't want their young children to get COVID-19. There were doctors, who were suffering from COVID while they were being pregnant, and still going on the duty. So, there are immense stories of human struggle and suffering on the mental health front, and also how we failed them in supporting at that point of time. We call them COVID-19 heroes or COVID-19 warriors. But when it comes to the mental health of warriors or healthcare workers, we know that they are the groups who often suffer the most, but then are not able to access services. So that's something that we really need to work upon.
Right. So all your experiences, Dr. Aqsa, have been very eye-opening and thought-provoking. So I would like you to please provide us a very brief conclusion. How would you like to conclude this conversation today?
I think, while we speak about urban health today in the context and with the background of COVID-19, in the background of providing vaccination, we need to understand that this was not the first pandemic, and this is not going to be the last pandemic. We will have such public health emergencies of international concern keep coming and challenging our healthcare systems. And therefore, it's important to go back to the basics of universal healthcare, to the basics of primary healthcare, and ensure that healthcare is provided to everyone, and especially to those who are marginalized on account of age, gender, sex, social class, migration status, or ability or disability. Because when we speak about universal healthcare, it's not only about reaching 100% in terms of quantitative coverage, but ensuring that especially it reaches everyone who otherwise would not have been able to receive the service. And that needs strengthening our primary healthcare services, strengthening our healthcare delivery, ensuring that the marginalized communities are involved in the process of planning, delivering, and later on evaluating our healthcare services. And finally, in understanding that every life matters, irrespective of whether they're an able-bodied person or a disabled person, a cisgender person or a transgender person.
So thank you so much, Dr. Aqsa. We assure you that this will be an ongoing conversation. We are going to invite any query or any other doubt that our Indian citizens would be having, and we would like to hear from you again. And thank you so much for engaging in this wonderful dialogue on quality, equity, and inclusiveness in urban public healthcare delivery. Thank you so much.
Thanks, Deepika, and it was my pleasure to be here.
Hello, fellow citizens. We have just heard Dr. Aqsa Shaikh. During the COVID times, Dr. Aqsa Shaikh managed one of the most successful COVID vaccination centers in Delhi. I and my wife got vaccinated from that center, so I speak from experience. This session is very important for the citizens of India to hear, to understand the core of quality, equity, and inclusiveness in healthcare. But it is also a great lesson for public health students, because after all, Dr. Shaikh is a professor and she teaches public health. She talks about vaccine hesitancy, and she says that vaccine hesitancy is an unacceptable term in today's times, because with vaccine hesitancy, the onus somehow is placed on the community and those who are receiving the vaccine. It should be the other way around. The onus should lie with us, those who are engaged in public health policy making, in designing programs, and in delivering programs. Because we will have to build the confidence within the community by ensuring that the awareness, the access,
and the acceptability of the vaccine is addressed, we also address the apprehensions that the community has. We will have to build trust. She demystifies what access means. Access has multiple components. One is around the confidence building, it is around the infrastructure, and it is around a trusted relationship between the community and the service provider. In this session, there are 4 key messages that we hear from Dr. Shaikh. The first is that vaccination rhymes with celebration. Vaccination is a celebration of life, but in order for it to be celebratory, we will have to share information transparently and truthfully with our communities. The second part that she talks about is about teamwork. The teamwork between governments, non-government players, academic institutions, and most importantly, the citizens of India. All will have to come together in an environment where they trust each other and take the program forward. The third thing that she talks about is how at the center that she was managing at the Hamdard Institute of Medicine and Research, HIMSR, how they had built convenience systems. For example, just to build confidence that in case any event happens after vaccination, they not only followed all the protocols and guidelines that the government had, but to add an extra layer of assurance, they had dedicated one elevator just for any emergency that might arise. They had opened up ramps and had dedicated ambulances in case any case needs to be referred. These measures go a long way in building assurance and confidence within the community to accept vaccines. But the final thing that she says, and is the most important and fundamental of the initiative that we are working on, the QEI, the Quality, Equity and Inclusiveness Initiative, is about the value of every life. That is the motto and the crux of our initiative. Every life matters. Celebrations of coverage must continue as we are celebrating the 2 billion plus doses that have been delivered of COVID vaccine, as we celebrate our routine immunization and our other public health programs. But we must also take into account the lives that remain somewhere in some corner of India and are not included in the celebration. As we said, every life matters, and unless every life is reached, every life is covered with the health services they deserve, we will continue to celebrate, but keep our watch that no one is left out. Every life matters. Thank you, Dr. Aqsa, for reminding us of the fundamentals of public health once again. Thank you.
Joining us today is Dr. Manohar Agnani. He is a public health professional and retired IAS officer 1993 batch with over 25 years of experience in the field of health systems, strengthening public health policy and planning, human resources for health, and RMCH plus N. He has a Master's of International Health degree from Copenhagen University and has worked and written extensively on public health, nutrition, and gender issues. He has also served as chairperson of the Interim Commission for Elite and Healthcare Profession and was nodal officer for India's national COVID-19 vaccination program, for which the team MOHFW, Government of India, received Prime Minister's Award for Excellence in Public Administration 2022. He has also received Distinguished Alumni Award 2023 for exceptional achievements and significant contributions from SMS Medical College, Jaipur, India. He has authored 4 books, including one called Missing Girls, which is about sex selective elimination of female fetuses, and has contributed to several publications and newspapers. Dr. Agnani, sir, welcome to this conversation today.
Thank you for inviting me.
I must begin with this conversation with a deep appreciation of the leadership you demonstrated in India's journey to deliver more than 2 billion doses of the COVID vaccine. We would like to begin our conversation today understanding specific plans to vaccinate the vulnerable population in urban areas. In our endeavor to vaccinate the adult population, particularly the vulnerable elderly in urban areas, India has demonstrated remarkable innovation and adaptability. 3 standout strategies have been implemented, including door to door vaccination campaigns, establishment of drive through vaccination centers, and also the organization of vaccination camps in residential societies. There were many different approaches, sir, that we heard from the states. Can you please tell us something more about the experience in the metropolises?
Thank you, Deepika, for asking this question. Actually, let me say that it was a team India effort. So I cannot say more than that. It was the every individual, every citizen, be it any uh, role, was he working for the ministry or for the state government, health department, tribal department, education department, NGOs, urban areas, local areas, PRIs, communities, any individual in all capacities, they have worked tremendously. So that is why what you see is that more or less we can say with confidence that the access was given to entire population, urban, rural, marginalized, remote areas, difficult areas, inaccessible areas, slum areas, and it was all inputs which we received from these sections of the society at how to best plan it. And when we were doing the planning, we were very open to this idea that we need to vaccinate the entire country. We anticipated there will be many challenges. For other vaccines also, we had some issues related to hesitancy. And this COVID vaccination was very different in a sense that we were expecting, anticipating eagerness also. So people may jump the queue. So designing a communication strategy to vaccinate the entire population, drafting guidelines for vaccination was something which was a difficult task. And I would say that before we begin the vaccination in country on 16th of January 2021, we had done that all homework and the vaccination related guidelines were issued way back in December 2022. As you rightly said, that we anticipated that there will be populations who will be elderly, there will be populations who will be differently abled. There will be challenges in urban areas. So we thought that how best we can make our strategy to vaccinate them. So thereby the concepts which you also said came that can we go near to the home and to vaccinate them through the involvement of resident welfare associations. Can we run the mobile vaccination teams for vaccination at home for those who are differently abled and those who have a restricted mobility? And for urban also, we thought that can we also design workplace CVCs? The idea was that if I am the head of the household and I go to my office, my entire family members can be vaccinated to the place where I work, so that the all issues around hesitancy, being together at this time when people needed to be convinced for the vaccination can work better. Similarly, for children, we thought that can we go to the schools to vaccinate them? So all the population groups were in our mind: old age homes, the persons who live in the differently able institutions. We thought of every organization, every institution, every workplace closer to them, and we were very confident we as a country can deliver, and that is how it has been done. So there are many examples. I may quote from many states. But suppose if I give an example of a state of Madhya Pradesh, they mobilized the municipal wards very effectively, and there were some the motor vehicles which were used for garbage collection. They were used for effective communication to reach to all the mohallas and all that. Not only Madhya Pradesh, there are many examples emerging across the country, and which really becomes a case study for future generations to follow.
Very well answered, sir. Very well said. And now moving towards that, how Indian government has taken several steps to increase the accessibility of COVID-19 vaccinations for vulnerable communities, including transgenders, persons with disabilities, and the elderly population. So, for example, in May 2021, the Ministry of Health and Family Welfare issued guidelines on near to home COVID vaccination centers, as you also mentioned, for elderly and differently able citizens to increase access to vaccination. Did you hear any inequity in vaccination for the marginalized population, particularly those with disabilities and transgenders? And were any specific plans put in place for them by the administration?
So we were monitoring vaccination on day-to-day basis, and we were trying that whatever the vaccination doses for vaccination are available, they are put to the best use. So the beginning was different. And as we started, we had all such challenges not related to particular communities or region, but it was, as I said, that was a lot of expectations from the population, and prioritization was put in place for the first time. So there were a lot of concerns. People thought that why they are not getting vaccinated and why this prioritization has begun. We were very clear that we will focus first on elderly. We will also focus on those who are healthcare workers, the frontline workers, because they were protecting us from being on in the front and giving those services. Coming to your specific questions related to transgenders and those who are differently abled or from the marginalized communities, we were monitoring on day-to-day basis, so we were getting lessons. I should not say that we were getting lot many complaints, but we were getting lessons that we can do better. And this day to day, it was a dynamic strategy which we were working on. We thought of a specific and targeted communication plan which to reach to those who are vulnerable and those who are in the marginalized communities, as you said about the different groups. But then state governments and the district government, they also did tremendous work. So this entire contribution goes to those who actually contributed in doing this. Again, I have many examples to say that how they were done. The transgender leaders were identified to be in the front in Chhattisgarh. They did it very well, exceptionally well. I remember an example was coming from Tamil Nadu. I think it was Kalakurchi district, where there was a festival of transgenders happening. It was called Chittiram Festival, and where the communities of transgenders from the entire India were coming to participate. And this was the time when there was no mobility restrictions, people reached there. And this opportunity was used very effectively by health authorities and the local government. They thought that this is an opportunity to raise awareness and to vaccinate and this population group. So they did it successfully. In Gujarat, they also anticipated that probably we need to have the special vaccination plan for these communities, and they planned for mobile vaccination centers to be conducted with the support of local NGOs for those who are transgender and MSM community. And vulnerables were not only restricted to these communities. I give another example. In Punjab, truckers, they were in a problem. So they thought of going to the truck parking lots to vaccinate those truckers. They did it successfully. Bihar example of Tika Express is a well-known example of the country. They took the help of all the NGOs, and they actually went to those areas which were slums in nature, where the construction sites were there. So every state was identifying the areas where they have less coverage or less visibility or less availability, and they were coming out with the local solutions. So this is something very extremely important to understand. So if you have the coal miners working in Jharkhand, Jharkhand came out with the strategy for how best we can vaccinate to those who are coal miners. And again, the civil society organizations took a very important role in this. And here it would be very pertinent to say also the Niti Aayog, they did with the help of Ministry of Health and Family Welfare, they did not less than a person who was CEO at that point to have a video conference done with the civil society organizations across the country and asking them to participate in this vaccination drive. And entire NGO community, they did excellent work. So if I do not make a reference to any one particular section of the society, it will not be a right thing to do. I think that this was done excellently, and ministry's role was to make those enabling provisions, as you said. How can we plan to the near to home vaccination or workplace vaccination or mobile vaccination, and similar things were done on COVID platform also. So that's how it is done. Also have beautiful examples coming from the difficult terrains, be it deserts of Rajasthan or hilly areas, and so on. So can you imagine the vaccine delivery is done on the camels and the healthcare workers going in those extreme weathers to the border areas and vaccinating? That's a great success. Similarly, in the hilly areas, we have many good examples coming from those hilly states where the healthcare workers not only took vaccine carriers on their shoulders, but reached to the highest points or smaller habitations residing there. So they are not left behind, not only maintaining the quality aspect related to vaccination through vaccine carriers and also vaccinating, doing the protocols, following the protocols, keeping their families at home and reaching late. Similarly, in the river areas, can you imagine the people, healthcare workers going on boats to reach to the areas which are less populated? So that is a good classical example of leaving no one behind and reaching to the hard areas. That was visible, that's documented, and we have many more examples. Similarly, for vaccine deliveries in far-flung areas, drones were used, which is being now used as a method, not only for the vaccines, but delivering the drugs, medicines, and blood bags to those areas which need such help. So India's COVID vaccination journey has given impetus to many more interventions and likelihoods in delivery of public healthcare systems in India.
Right, sir. Right. So you, sir, shared very well examples with us, including Punjab and Bihar's, how the vaccination campaigns were supposed to be taken near to the people. And now, so moving forward, now let us talk about the role of technology. So, as all of us are well aware about how COVID has been a game changer in the COVID vaccination. So, how did you ensure during those times that technology does not become a barrier to immunization coverage and demand for COVID vaccination?
Thank you. So I'm a great fan of COVID platform, and it was not a small effort. The ministry and the government of India actually realized this well in advance, and they formed an empowered group for COVID vaccination to deal with aspects related to COVID implementation. And no less than Dr. R.S. Sharma, who was authority on IT platforms and did excellent work in past, was made to chair of that group, and all the ministries were working on this along with the Ministry of Health and Family Welfare being the nodal ministry for that. So I was also privileged to be part of that committee as convener. So the thinking was very clear. Thinking was very clear that we need to work on COVID. One, we should make that COVID a platform which is accessible to all. So, and every record of vaccination has to be recorded on COVID, and a certificate has to be generated so that in future we have a lot of understanding knowledge of who all have been vaccinated by which vaccine, because to begin with we started with two vaccines which were of different nature, so one needed to vaccinate with second dose of the same vaccine. So a platform was definitely required. COVID was the beginning, and about the access to the citizens when it was thought of, we thought of several routes. So first was giving the advanced self-registration. So those who have knowledge and understanding of internet and IT systems, they can do on their own register for themselves. But those who did not have access or the understanding or the knowledge, we thought of them also to begin with. So the facilitated cohort registration was thought. Similarly, on-site registration was something which was planned. And also we thought that we will not impose such restriction which are a way in easy access for the vaccination. So a lot of documents were thought of to begin with for identification of such individuals, and the Aadhaar, driving license, PAN card, passport, voter ID, ration card with photo, student ID photo, whatever was available was thought for registration on this. But then I must make it very clear that online registration and prior booking was not mandatory. So COVID offered additional modes for registration and vaccination, as you also said that on-site or walk-in registration for vaccination was available. Similarly, so as I said that cohort registration, a group of people can just walk in or can be mobilized by the local community, and we have many successful examples around that also, who came on the vaccination side and got them vaccinated. Similarly, the common service centers were very important. They also played a great role in assisting registration of those who need to be vaccinated. And similarly, if you remember, we had a very popular helpline 1075 when we started with the COVID-19 to begin with helpline. And that helpline was also used for vaccination, and that also assisted many people for the vaccination. And people who did not have any documentary proof for themselves, we also made special plans on COVID for conducting sessions and facilitation of people who did not have any of such documents. So I would say COVID was enabler. We had hardly any informations related that people, because of lack of access or knowledge or understanding of technology, were denied of vaccination. In fact, COVID actually proved enabler for such vaccination.
Yes, sir, I agree. Whatever you said, and there are various studies who has actually documented all these enablers during COVID-19 vaccination journeys, and COVID is one of the prominent factors that we were able to mark this ambitious journey with India. So now, sir, thank you so much for sharing such insightful and relevant information with us. And as we are approaching towards the end of this conversation, how would you like to summarize or conclude our conversation today?
Okay, thanks. So this COVID vaccination is a great journey.
Hmm.
It is a great example, a good example of India as a collective team working on the vaccination front. It has many lessons for the future also, that it gives us a confidence as a country that if in future we have such problems or pandemics, we can deliver and we have capabilities. We are one country. We work in such emergencies very well. We have shown to the global world. That is one. Second, this entire journey also is a good example that what all should be thought of in such emergencies or doing the mass level vaccinations. Third, it also gives us a confidence that our journey from even to COVID was very successful, and now it is a good time that we vaccinate our entire population, children, pregnant, adult, all the vaccines in time, and that journey has started. So COVID is now converted into UIN. So we are saying of the universal immunization, and why only immunization. Taking good examples from this, we need to work on all health delivery aspects related to primary health care for all the populations. I'm very confident that with the National Digital Health Mission, talking of creating ABHA IDs of all individuals, creating a profile of all healthcare professionals and all healthcare institutions, we will be able to create an ecosystem. We already begun on that, where every individual will be given services closer to the community, which are of quality, which have equity in lens, which are inclusive in nature, and this out-of-pocket expenditure on primary health care will get reduced further, and that will be a way for universal health coverage, which India can definitely achieve. That's my thinking, and we are on that road. I'm very proud of my country. Thank you.
Great to know that, sir. Great to hear that. And thank you so much for this informative conversation today.
We have just
And
listened to Dr. Manohar Agnani. Dr. Agnani was at the forefront of India's COVID vaccination program and is one of the most suitable persons to narrate how more than 2 billion doses of COVID vaccine were delivered in India with quality, equity, and inclusiveness. There are 5 things that Dr. Agnani highlights in speaking of the planning and delivery of COVID vaccines in India. The first is around partnerships. Every department, every institution, and every citizen of India joined hands to overcome the challenges that lay in the path of COVID vaccination. This partnership is unique because of the urgency and the efficiency with which it had to work. The second point that he makes is around the prioritization process of the entire population, particularly in light of the eagerness that citizens of India had for getting the COVID vaccine in time. The effective communication strategy that was put in place to address the eagerness and any fallout that may result from the prioritization process was handled very well by the Ministry of Health and Family Welfare in partnership with various other agencies. The third issue that Dr. Agnani highlights is on the effective planning at local levels. For example, the plan to vaccinate a large number of transgender people when they had come for an annual gathering in Tamil Nadu, or the role of transgender leaders in Chhattisgarh for building confidence in the community for vaccination. The fourth issue is around governance. Good governance, as demonstrated by the empowered group on COVID vaccination, of which he was the convener. That led to the successful rollout of technology, the CoWIN technology with which all of us are familiar. The planning process for rollout, the continuous learning mechanism, and the direct dialogue with the civil society, as was done by Niti Aayog, were critical for ensuring that the technology turns to be people-centric. And finally, Dr. Agnani speaks of innovations, technology and planning innovations, the use of camels in deep deserts of Rajasthan, or the use of sophisticated drones to overcome challenges of access in difficult to reach areas of the country for delivering vaccines. He ends with a note of optimism. India is prepared now to face any future pandemic. The lessons that we have learned, the tools and technologies that have been adopted, and the confidence among Indians, Indian citizens, is that we can win. And this is an overwhelming phenomenon in the citizens of our nation. We too are with you, sir, proud of our country and our fellow citizens.
Joining us today is Professor Satendra Singh. He is the Professor of Physiology at the University College of Medical Sciences, University of Delhi. He is a noted disability rights activist and the first person from India to be awarded the Henry Viscardi Award in 2017, which honors exemplary leaders in the disability community who are reshaping societal perceptions and making significant changes in the quality of life of people with disabilities. He is also a member of the Core Group Committee on Disability at National Human Rights Commission. 13 years ago, he and his mentors founded the Medical Humanities Group at UCMS, the first such initiative in a medical institution in India. Along with the Buxbaum Institute, the group framed disability competencies for health professions education to improve the doctor-patient relationship. He is also working on supporting decision-making among marginalized population, especially people with disabilities. So, Dr. Singh, welcome to today's conversation. You have been a champion of rights which include the right to physical, social and mental well-being for people living with disabilities. So, we have been discussing over the time that innovations in urban primary healthcare centers can significantly improve the accessibility and quality of care for the people living with disabilities. So, we would like to begin by hearing about the challenges that PLWDs faced during COVID-19 period and what are some of the structural policy and structural barriers that they faced in availing the public healthcare services?
Thank you so much for having me on the show, and this is a remarkable QEI initiative. And coming from the disability background, you asked a very pertinent question on the experiences of people with disabilities during the COVID-19 pandemic. Unfortunately, most of the people with disabilities, they were locked down and left behind. If you look at the definition of the word ableism, it means that when you discriminate on the basis of mind-body differences, and it largely comes from the notion of quote-unquote normalcy. Now, people with with disabilities have different specific needs based on their specified disabilities, and that is exactly the reason when we say between equality and equity. Because when we say equality, we are providing the same provisions to each and everyone. On the contrary, people with disabilities, they have a diverse set of healthcare needs. And that is why it was important that we need to cater for those needs, which was not taken care of within the pandemic duration. For example, we all saw that we all were glued on TV screens watching about all the important health advisories coming out from Indian Council of Medical Research, Ministry of Health and Family Welfare, and all big autonomous bodies like Anti-Vax, also Vaccination Advisory Board. But how many of them were using closed captioning for deaf peoples? How many of them were included the sign language interpreters in them? So we were removing a large section of society who were people belonging to the deaf community. And similarly, when the advisories were being released time and again, one after the another, many times these were not accessible to the blind community. Many a time these were not accessible to those with intellectual disabilities because these were not in easy to text read, or these were not having the pictorial graphic representations. Also, even the higher bodies, which frames the policy outside India, they use the words like social distancing. Now, if you look at the country like India, which has a huge geographical diverse population, it has different connotations in our country because we still are grappling with the inequities in the form of socially outcast communities like Dalit community, like people affected by leprosy who are isolated in segregated colonies. India has the biggest colony for people affected by leprosy in Asia, and also people with intellectual disabilities who are institutionalized. So I think a better thing would be to call it physical distancing. We can be socially connected, but can be physically distanced. Then also, if you look at the various initiatives taken from the government, they were far too little and too few, because the ex gratia amount given to people with disabilities was a meager 1,000 rupees given in two installments. And majority of the disabled people in India, they live in rural areas, 69.9%. And most of them are working in an unorganized sector which is not regulated. Some of them are migrants, some of them do not have any employment and jobs like that. So these are the things which perpetuate to health inequities also, and the social security schemes which were there were not up to the mark. Also, if you look at our new disability legislation, which is a very promising rights-based legislation, it includes newer disabilities. Like there are three based on blood disabilities: hemophilia, sickle cell disease, and thalassemia. But during the lockdown, we saw that there were prevention of mass gathering, and many of these people are dependent upon repeated blood transfusions. So we were putting them at risk, though they were legally protected, but efforts were not taken into considerations to look at the needs of this population, if I may say. Then, of course, there were some good examples. There were some very good, resilient, and inclusive practices across the globe. For example, the Republic of San Marino was the first nation who came up with a triage policy for people with disabilities when other countries were still framing their policies. There was a very good example in the form of Canada. Government of Canada, they created a disability advisory group at the top level. Unfortunately, we did not see any such event happening in India, so they were directly involving those people in the advisory board, and within Ontario itself, there was a COVID-19 scientific advisory group, and they came up with the guidelines that people with disability needs to be given at-home vaccination because they involve the disability community. And then, of course, we saw some more promising practices like during the lockdown, the caregivers of disabled people and people with disabilities, were exempted from the restricted movements during the lockdown, because many are dependent upon their physiotherapy care,
Right.
and some of them are totally dependent upon their caregivers who may be living in different places. So in the countries of Panama and Paraguay, such practices were allowed. Then we also saw that in the country of Peru, they used accessible format
Right.
for dissemination of informations. For example, sign language interpreters and information and easy to text read. Then in the John Hopkins Institute at the United States of America, they come up with a COVID-19 COVID prioritization dashboard.
Okay.
So which was a great initiative, so they could actually prioritize that which are the communities which needed, the most care within the disability
Right.
community. Even there were some examples in India, like Ministry of Social Justice and Empowerment, they come up with the Kiran helpline for mental health support. So
Right.
there was a great initiative, and also the High Court of Delhi, they passed this judgment that people with psychosocial disabilities who are homeless,
Yes.
so people having psychosocial illnesses and who have no home, so how to test them, how to treat them, because government was insisting on IDs. So they said that they can use the 9 times 9 digit number
Okay.
to fill up for tracing, contact tracing, and identification. And for ID, the beat officer of that police area, they can give their ID, so that even the homeless people are getting their rightful due of having proper urban health care services within India.
Right, sir. So, sir, while speaking about the accessibility towards these healthcare services for persons with disabilities, you talked about the role of IT also. So, according to you, sir, when we are talking about artificial intelligence, how technology can become a booster to provide these services quickly to the people with disabilities?
So I think artificial intelligence, in my opinion, is a game changer for people with
Right, sir.
disabilities, because now many of the, for example, blind people in India right now, they are not dependent upon braille. Most of them, they are using screen readers, and they
Right.
are using technology in their day-to-day life. So in fact, they can communicate, they can use all the social media tools. Even those who are having sensory dual disabilities, like those who are deaf blind,
Yes.
those who are both deaf and both blind, it is very difficult, to imagine how we can communicate with them. But here comes the role of the technology. They are on all social media groups communicating effectively with the use of technology. And I think that's why it is a great enabler.
Right.
Because if you look at the most recent World Health Organization's 2022 global report on health equity for persons with disabilities, they say that around 16% of the world's population experience disability. That
Yeah.
means 1 in 6
Yes.
experience disability, and we are the world's largest minority. Within this population, 1 in 3 older people have a disability,
Okay.
but 1 in 10 only gets an access to an assistive device,
Okay.
which is also important to those who are elderly people, because when we grow old, of course, our
Yes.
senses diminish, and we are going towards becoming people with disabilities. So that's why it is very important that the need of assistive devices can be taken care of, because it is not available globally. We are still creating world records and distributing
Right.
low cost assistive devices.
Right, sir.
So the time has now come, because assistive technology, now we talked about the sign language interpretations.
Yes.
AI can help in actually transmitting signals from the sign language to audio input, or the vice versa, speech to text or
Right.
text to speech. AI can also transform the lives of people with disabilities when we are talking about independent living.
Okay.
Right now in India, it is, we all love movies and cricket, but
Yes.
how often have you seen a wheelchair user sitting next to you in a cinema hall in India?
Yes.
How often have you seen a wheelchair user praising his own T20 cricket team in IPL? We have not seen those images. So where is the social inclusion? So here comes the concept of independent living, because when we are using this technology, they can use those sensors which can be applied on their mind, even if they are amputees, even if they are having missing body parts, even if they are using prosthetics and orthoses. These sensors can detect muscle movement and transmit signals to the brain. So by just using those head mouses, they can control the environment of the hall. They can switch on and switch off the lights, and they can control the external environment with the help of assistive devices.
Right.
So that is a great way forward for having artificial technology.
Right, sir. And sir, according to your experience, are there any technologies which have actually enabled the people with disabilities to access public health care very easily?
So one of the example is that, of course, during the COVID times, we had the COVID app, which was there.
Okay.
So many times when you are following the guidelines of the GIGA, which are the on web accessibility,
Right.
you are allowing people with visual disabilities and those who are having cognitive difficulties,
Yes.
they can very well get the information. So that is one example. The second example was, of course, IIT developed a smart cane. But now with new advances in artificial intelligence, we can see the obstacles coming in front
Right.
because of that. So that even the blind people, they are not dependent upon others. They can identify the obstacles and all that. There are few apps which can also tell you about the external environment which is there, and many blind people are using that. So these are the things by which you are not dependent upon only the tactile pathways.
Right.
Rather, the technology is in your hand, and many of the people now are using mobiles, and just by downloading these
Exactly,
apps,
sir.
their lives are becoming very independent.
Right, sir. And related to this question only, as you have provided us few examples where the medical services and public health services were made accessible to the people with disabilities. But when we go back to the COVID-19 time, we have seen the impact of COVID-19 on mental health of these population segments. So my next question is related to this only, sir. Are there any steps which were taken by the government, or what are the steps, some of the steps that government, communities and family members could take, particularly for the PLWD population, the ones with living with disabilities, or the transgender population also?
Yeah, so that's a very pertinent and very valid question, because we saw during the lockdown also that some form of disabilities like autistic people, neurodivergent people, and those who are having specific learning disabilities, they they become very anxious when their routine is disturbed, and that's why during the lockdown it put a lot of barriers. In fact, there were stories coming out from both Dehradun and Chandigarh that autistic individuals were fined by the police because they were not aware that why they are roaming outside. So that's why it is important to understand those developmental disabilities. And again, we saw that within the hospital setup also,
Right.
they were not allowing a caregiver, and it was difficult for those youth with COVID-19 who were having autism to take care of them,
Right.
because they were dependent upon their caregivers. And that is why it is important to talk about, for example, in Delhi we have the good example of having mohalla clinics.
Yes.
And there are other small setups also. So we can convert few of them into sensory clinics,
Okay.
so that they can take care the specific care of people with autism or learning difficulties, because sensory clinics, they cut down on the noise which are there. So many times they are very apprehensive of the noise, external noise.
Okay.
So there are ways by which you can develop these to cater specifically for this population of people. And similarly for other group of people also, we also that a lot of people were grappling with depression and mental health issues, and of course the disability and the transgender community, they are more vulnerable to these changes.
Right.
And of course we saw during the vaccine equity programs also that they were left behind. There were no dedicated and separate services for them initially, though they were they came later on. But of course it makes sense to have those near to home COVID vaccination centers exclusively in the old age halfway homes, for example, in the mental health institutions, or where there are people with disabilities are residing. And what government can do is that, of course, it was our long pending demand to have a national suicide prevention strategy. So the committee was constituted, but it took a lot of time to come up with the guidelines, and finally last November they come up with a strategy.
Yes.
So it makes sense, because when you are saying strategy, that means that you are talking about a sure direction. So
Right.
it makes sense to have that rather than a policy. But though it was a very good initiative, and now we have a plan, a roadmap how governments, institutions and communities can move forward.
Right.
But the problem is that none of the people, we did not took into consideration the lived experiences of people with mental health issues.
Okay.
In the committee, there were no person with the lived history of suicide or suicide survivors.
Okay.
So when we are framing these guidelines, I think in the disability rights movement, we often say this, nothing about us without us. So when you are making national guidelines, policies, you need to involve those people because they have gone from that to that stage and they know the best possible solutions to that. So that is one thing, and of course, no health is fine until unless you include mental health component into that one. But of course, the mental health component also involves the the human rights issue of disability, because we need to talk about the autonomy and dignity of people with disabilities. So it is important that right from the community level also, the Mental Health Care Act and the national policy on mental health, it talks about district hospitals, having psychiatrists. But of course, the problem is, which is a logistical issue, we do not have that many number of psychiatrists in India. So that's perhaps the thing we need to see, that we have limited number of psychiatrists. So maybe that's why we need more of the the counselor and the psychologists which are there, and it needs to be there in each and every higher education institutions, because you can't get psychiatrists everywhere. So that's why we need a massive setup where we need to include people, so that when we're talking about mental health, we are talking about community mental health, and we are talking about resilient initiatives, so that nobody is left behind.
Right, sir. So this is truly inspiring, sir, and this was truly enlightening conversation, sir. So if I ask you to conclude in few lines about improving the accessibility and improving the quality, equity and inclusiveness towards primary healthcare services for this segment of people with disabilities, how would you like to comment, sir?
Yeah, so in short, when you're talking about quality, when you're talking about equity and inclusivity, I think the important thing is that, as I earlier said, that nothing about us without us. We need to involve the lived experience of those people who are having these experiences, be it the disabled people, be it the elderly people, be it those with mental health issues, or the transgender populations. You do involve them in these decisions, as you're doing right now. And the second thing is that now these issues are everybody's job. It is not something that only the community people, we should talk about these issues. We need allies, we need government, we need community to own up these issues and talk more about equity, equality and inclusiveness.
Yes. So this was, thank you so much for this conversation, sir, and this was very engaging and enlightening conversation.
Hello, fellow citizens. We have just heard Professor Satendra Singh, his thoughts on quality urban healthcare that is equitable and inclusive. He speaks from his vast experience of working for right to healthcare for the marginalized population, particularly people living with disabilities. In the conversation, he also highlights examples from the recent pandemic, from India and from the world, to make his recommendations. The recommendations that Professor Singh puts forward are evidence-based, actionable, and have been tested elsewhere in India and beyond. The positivity in his tone throughout the dialogue is also refreshing. These reforms can happen, and hearing him, I get a feeling that these reforms will happen in tomorrow's India. There are 4 things that I am taking from the conversation. 1, around the philosophy and principles of policies. For example, the government has to think of distancing to prevent transmission. Think of physical distancing. The term social distancing is unacceptable in human civilization. It makes one feel almost as an outcast. 2, inequity is the derivative of a complex socio-economic phenomena. It is not just about access. The lack of financial stability, lack of user-friendly tools and devices, and the flaws in policies, program designs all contribute cumulatively to inequity. The third thing that Dr. Singh highlights is the promise of technology, artificial intelligence. So many doors, windows, and paths of opportunities can be opened with the pragmatic use of artificial intelligence. Again, the wide-scale access of these technologies and devices must be assured. Finally, I loved the evidence Dr. Singh highlighted from so many geographies and governments. From our QEI initiative, we will document these into a white paper for advocacy. The simple administrative and public health measures from Paraguay to Ontario in Canada and from Johns Hopkins University in Maryland, USA, they can be great guides to transforming India's healthcare for the marginalized population. Hearing Dr. Singh speak so eloquently and positively was a treat. Documenting his thoughts and evidences will be our duty to inform the government systems to act on quality, equity, and inclusiveness in urban healthcare.
Joining us today is Dr. Benazir Patil. She is a seasoned professional in the field of public health and is currently the CEO of School of Community Health Oriented Operational Links, India. Dr. Patil has a PhD in public health policy and has been instrumental in public policy, policy analysis, advocacy, and strengthening health systems. She has also been involved in developing results frameworks and designing communication strategies. As a researcher, she has been a principal investigator for large-scale baseline, endline, and implementation research studies in India, Nepal, Bangladesh, and the Middle East. Dr. Patil is the founder and advocate of a national level initiative called Vriddha Mitra, Friends of Older People, which aims to ensure better healthcare for all and life course. Dr. Patil, first of all, allow me to congratulate you on the service that the Vriddha Mitra team provides to the elderly population in terms of physical, mental, and social well-being. I hope you will reflect from your experience on some of the challenges the elderly population faces in availing of public health services, and if you have any solutions that you would like to speak of. Dr.
Thank you so much. And I'm very happy to be here and share about our work. Your question is very pertinent. And let me just take a few minutes to brief you about the program. The reason is people still think that we are an institutional setup. So there have been times when I have presented the program, talked about our work, and then in the end people ask, where is the old age home? So frankly speaking, the name that we have, school, when the organization was founded, we all thought that we'll work with school children, we will work on school health. But there came a time in 2018 when we took a policy decision to work with elderly people. And it was very important to decide the strategy, the ways of working. And we chose to go non-institutional, meaning we didn't want to get into an institutional setup where we can just serve handful elderlies, 50 or 100 people. Also, the reason was that having worked in public health, 50 and 100 number cannot look, good for you. You want to look at millions of population, and so in the past, all of us in the organization worked with millions of mothers, millions of under fives, millions of newborns. So it was very difficult to think of just 50 or 100 elderly, and we decided to go community based. So Vriddha Mitra program was created with an understanding that an age group of this sort really needs companionship at the core. So because if you see today, in some ways nursing care, in some ways support systems are available, but when it comes to companionship and all the support that can actually be given through this companionship, whether it is healthcare, whether it is counseling for mental well-being, whether it is ensuring social security, all of that through companionship is worth it. So we started this program in 2018 and we started our first community-based project in Pune in January 2019. And that time also for people it was a big project because we were serving 600 elderlies in the community. And from then onwards, from 600 elderlies to 33,000 elderlies today, it has been a journey of last 5 years. To tell you the truth, if we talk about public health care, support systems, health systems for the elderly, it is unfortunate that we've not been able to focus. Also, I think the country is at a level where children are being prioritized, under 5, adolescents, youths are being prioritized. So it's nobody's mistake. But today, if you see, this is the most neglected age group. So in terms of dedicated space for healthcare, we don't find. For example, we rarely find a geriatric ward or a geriatric unit in a hospital. In terms of healthcare services, which are at the OPD level or primary healthcare level, we will rarely find a board anywhere around the PHC that on so and so day there is a special OPD for elderly people. Like we have OPDs for ANCs and PNCs, there are dedicated days for them. Similarly, you will find OPDs or dedicated days for any kind of immunization for children. But no such facility exists for just the older people. Also, if you see, when you go to any health facility, whether it is primary or secondary or tertiary, you won't find a separate row for older people or a separate counter for older people. So the whole idea of Riddha Mitra is to create an age-friendly ecosystem for the elderly population in India. And within that, we have different divisions. Community-based mechanism is one of our divisions. Research is another division. And within community-based mechanism also, continuum of care for health is a very big chunk. I would say that about 80% of our interventions are focused on healthcare. And these interventions actually encompass the entire continuum. Let me just tell you the pathway of how we go about doing it. So to begin with, visiting the elderly at home, doing a home health checkup. Our community workers have a kit. They can check sugar levels, blood pressure levels, their oxygen levels, their temperature, all of that. If there is a challenge, immediately they are trained in doing a teleconsultation with the in-house doctors. So once the teleconsultation is there, there is a clear referral pathway. The doctor may either suggest that there needs to be change in medication, or the doctor may suggest bring the person for physical OPD on so and so day, or the doctor would suggest that let us get a basic test done or a diagnostics done. So there starts the pathway. From there on, the elderly is taken for the OPD. From OPD, it could be any center for diagnostics. From there on, it could be a matter of surgical intervention. So a lot of support is provided in the surgeries because they have to be linked with various government schemes and programs. They have to be getting health insurance coverage, all of that. And then once the person is back after the surgical or any kind of intervention, again, the person is back at home. So one has to be given moral support, counseling for mental well-being, ensuring that the medication is taken properly, ensuring that the family members are taking care, also counseling the family members on diet and nutrition. So there are multiple ways, but at the end of it, we are there for the entire continuum of care for that elderly. So at this moment, if you ask me, that something like this, if all of us can do in all locations of the country, we are sorted, because at the moment, We have systems, we have plans, we have clear referral pathways for sick newborns, for pregnant mothers, for adolescents, for a person suffering from NCDs, but we don't have for geriatric care.
Right. So very well answered, ma'am, and very enlightening answer also. Moving forward, ma'am, as we have seen that the National Program for Healthcare for the Elderly People in India has implemented several elderly-friendly policies and programs. These include the establishment of geriatric clinics, as you said, at various levels of healthcare delivery, and the provision of home-based care for bedridden patients. Additionally, the Vyo Shrestha Samman, initiated by Ministry of Social Justice and Empowerment, recognizes individuals, institutions, and NGOs for their services towards the cause for the elderly. Such practices, if scaled up, can significantly improve the health and well-being of the elderly population. So, similar question, my next question for you would be, what are the some practices you have adopted to serve the elderly community? Some practices that the community has embraced can be adopted on a large scale within the current health infrastructure.
Okay, very well said, Dr. Deepika. Yes, National Program for Healthcare of Elderly is absolutely wonderful program. It almost covers everything that we need to do in terms of healthcare for the elderly people. But there's one more thing to it. See, and I wouldn't say we, because we are in nascent stages today. Most of these programs at any of these programs, whenever these programs started, they were like islands of excellence in different locations, and these islands of excellence or centers of excellence need replication as well as scaling up. If we are not able to do that, then it's a challenge because we are ending up serving a handful of population and not the entire country. So looking at this, one of the strategies that we have had in our intervention also, that we also could have created a small project somewhere and have shown the entire demonstration to the world that this is how the projects or a community-based mechanism for elderly should be created and implemented. But we've done two things. So I talked about replicability and scalability. If that is not there in the intervention, then it's not worth it. So what we have done in our program is, as I mentioned earlier to you, at one level, for example, when we started in Pune with 600 elderlies, we have now reached 28,000 elderlies within Pune. So we have scaled it up. So the program is tested, tried, the proof of concept exists, and now we have scaled it up and it's going way forward, and probably in next 2 or 3 years we'll saturate the entire city, meaning we will reach every elderly residing in the slum. That is how it is going ahead. At the same time, we've also tested the replicability. We have taken this program to 3 other geographies. We've taken it to Mumbai, we've taken it to Bhopal, and in Gwalior, we've taken it to rural areas. So again, there is tweaking and, small modifications in the model in a place like Gwalior, where the requirement is for older people residing in rural villages, remote villages. So first thing what we've done is this. Second is the best practices or good practices that you're talking about, or innovations specifically. Now, in all these locations, we are not working in isolation. Our first primary objective is to work in collaboration with the local bodies, be it a municipal corporation or a district authority or different departments that are working for the benefit of elderly. And it includes all those departments that provides social security entitlements and schemes. So what we have done is we have continuously been meeting them, bringing them to the field, showing them the challenges, and also jointly arriving at solutions that we can actually develop. And one of the best solutions, which actually was again started in Pune, is a geriatric unit. So in 2020, just after the first wave, the Pune Municipal Corporation took a decision that we need to have dedicated spaces. And for example, Pune is divided into 5 zones. So every zone should have a dedicated space where there should be dedicated healthcare services for elderly people. So the first geriatric unit was started immediately after second wave in 2021. Today we are having 3 geriatric units in Pune. This geriatric unit is also now in Bhopal, also now in Gwalior. So you see, when there is a valuable innovation, the governments are also not behind. They also want to replicate it. Now, what are these geriatric units? Why they are so important for our elderly? There are OPD services starting from physiotherapy, dentistry, diagnosing and treatment of NCDs, ophthalmic care, all of these services being provided in these units. And it is interesting that the slum level elderlies who actually cannot afford this kind of care in private hospitals, because it's just impossible to go to a private hospital and do physiotherapy one session. They are all brought into an ambulance from their community. Services are provided and they are dropped back at the end of the day. So it is absolutely at no cost. And this same model is working in all 3 geographies I mentioned. And it is a big contribution to reduction of out-of-pocket expenditure. So these kind of innovations, if we demonstrate and we take it to other cities, the cities are willing, the districts are willing to take it ahead. And I think it is time we start taking these demonstrations to all other geographies in the country. I don't know if I answered your question.
No, ma'am, you have very well answered. We have really came to understand about various innovations that can take place in future also to scale up these operations towards serving these elderly people, of course, and also the role of replicability, how important it is. Now, I would like to shift your focus from, talking about the innovations and now talking about the mental health related issues. Right. So the research underscores the need for a comprehensive approach to mental health that includes prevention, early detection, treatment, and rehabilitation. This is particularly important for vulnerable populations such as elderly, people with disabilities, and the transgender population, who actually face additional barriers to, assessing this mental health services. So, and also, ma'am, we have been hearing from mental health practitioners that the long COVID sequel have had a significant impact on people's mental health. So, in light of this suboptimal mental health awareness and delivery care, what are some of the steps that governments, communities, and family members could take, particularly for the elderly population, those living with disabilities, or the transgender populations?
This is very important aspect that you're touching upon. Let me tell you, we all have suffered a lot during the pandemic. And I think if you remember the first wave and second wave, all of us were feeling as if it's no more a disease pandemic, it is a pandemic of isolation and loneliness and impacting our mental well-being. And somewhere I feel that we should also thank this pandemic, that it created an alarming situation for us and it opened our eyes that we need to focus on this aspect. So before the pandemic also we were working on mental health, but yes, we realized the importance all the more during the pandemic, and there were certain very key steps that were taken by us. Very first step was training our own staff. We went a step ahead in capacitating them in how to counsel for a person who needs mental well-being, how to address some of the challenges at the very home level, how to understand the challenges that they are not able to deal with, and those should be referred ahead for professionals to come in for counseling. We started looking for places where we needed privacy for counseling. We started interacting with organizations that were at different levels of mental health interventions. I would give you an example that at the moment, in every geography, we have at least 5 such organizations, dedicated organizations that are working on mental health, with whom we collaborate, who come to the field, who provide sessions, who provide medication, who provide, the mental well-being support to the elderly. And these also include elderly who are suffering from some of the chronic diseases like cancer. So that was another step that we took. Third important step was that we started understanding the referral pathway for a person who was going through this stress. What are the needs and what we should be doing for that person. That is something that we started doing. We took help of tools like MHGAP, because if we have to deal with anxiety or depression, we should also have certain tools in our hand to take care of those things, because everything cannot be referred outside. Some basic primary healthcare should be given right at the home level. So that was also another thing. We had some very good WHO professionals giving us training, online trainings, and I'm talking about all this in first wave. When the world was shut down, we were getting online training, online counseling, and all of that. And we also realized that it was not just for the elderly. It was being required for us also, because we were also going through trauma and bereavement of the deaths that were happening, the hospitalization that was happening for the elderly, because we also start getting bonded with them. So that also started helping us. So one of the things that we should be doing, and one more thing actually happened as a byproduct, which has been continuing since then, is all our community meetings, the meetings where we try to remove this stigma, where we try to tell people that this is normal. All of us go through this kind of anxieties. All of us feel depressed. All of us are wanting to seek help. All of us need to go and get counseled. So all these things, then also making the family members understand the challenges of the elderly and how that elderly should be treated on various occasions, especially those who are suffering from chronic illnesses, the fear that they have. All of that has continued now for last so many years, and it has been wonderful. We regularly conduct these meetings in the community. People have come forward, people have started volunteering. They are a part of our mental health camps. They are a part of our counseling sessions. They are also the ones who conduct recreational activities. So we started with a lot of activities for the elderly, which engages them, where they can learn something, small things, they can learn something new, some skill set, even if it is making garlands or chota gajra or whatever, those kind of things. Then having recreation sessions where they sing, they do Zumba, they do dances. It really helps and it works for them, and it's been a wonderful journey for us. I think COVID made us learn a lot. We wouldn't have speeded up so much had it not been for COVID, actually.
Right, ma'am. Very well said.
We have just listened to Dr. Benazir Patil, the founder and CEO of Briddha Mitra. Dr. Patil and I have been colleagues across organizations in the past, and we know each other for over 2 decades. As Dr. Patil was speaking, I had shut my eyes, trying to visualize what she was narrating. She is, after all, a storyteller and has 2 published books to her credit. The Bridha Mitra concept that she and her colleagues have materialized is a platform dedicated to health of the elderly, health in its true form, physical, mental, and social well-being of the elderly population. The central pillar on which the platform stands is the fulfillment of companionship, a critical need for the elderly. In addition to this central pillar, there are 4 pillars at the 4 corners that support the Bridha Mitra platform: community-based primary healthcare services, research, capacity building, and continuum of care. In her conversation, Dr. Patil mentions 4 very important things. I'd like to draw your attention to those things. I consider these 4 things critical to sustainability of a public health program, particularly around large programs like healthcare for elderlies in urban India. She speaks of the need of innovations that will propel programs forward. It is these innovations that draw attention of governments, and the buy-in of the government is key to sustainability of a program. Somewhere thereafter, Dr. Patil speaks of scale of services at the community level. Dr. Patil does not say specifically, but there is a hint in her narration of the need for integration of services as a condition for scale to impact. And finally, Dr. Patil speaks of Bridha Mitra's models of affordable healthcare for the elderly. And as I told you before, Dr. Patil is a storyteller. How beautifully she navigates the plot, from innovation to drawing attention of the government to sustain affordable healthcare models for the elderly. A brilliant rendition of how urban healthcare for the elderly can be delivered to ensure physical, mental, and social well-being of the elderly in our community. Thank you, Dr. Benazir Patil. As we now conclude this enlightening QEI dialogue on urban healthcare, it is my privilege to extend a heartfelt vote of thanks to all who have contributed in this conversation. First, I'd like to express our deep appreciation for our esteemed speakers. The speakers, Dr. Aqsa Shaikh, Dr. Benazir Patil, Dr. Satendra Singh, and Dr. Manohar Agnani. They not only agreed to speak to us on this important issue with their experience and wisdom, but also they had a very frank conversation on this subject. They spoke transparently and they provided us with many guidelines about how we should move forward in this journey. I'd like to extend my deep appreciation and thanks to colleagues Professor Sanjay Dhir and Dr. Deepika Sharma and the entire team at the Department of Management Studies at IIT Delhi. Thank you for your tireless efforts in organizing this event, your dedication, commitment. They have been instrumental in facilitating this important conversation. Most importantly, As a team, we enjoyed the entire exercise very well. I'd like to thank you, our audience, because everything that we do is ultimately dedicated and meant for you. You will continue to collectively guide us and take us forward in this journey. We hope to hear from you on the diverse perspectives that you will have in order for us to really respond to the questions that you have, to enter into a continuing dialogue. And I request all of you to send any questions that you have to our dedicated email address, which is there in the link. It is qei.publichealth@gmail.com. Please write to us, and if you would like specific answers from specific speakers, then do mention their names and we will get the response from the speaker. Lastly, I think we will all join to thank and feel blessed about being a citizen of this incredible country that is India. We have heard from all the speakers and we have all lived the experience that we have had during the COVID vaccination time. The kind of response that the citizens of India showed in addressing COVID, a pandemic, is incredible. We live in incredible India and we feel blessed about having that opportunity. We will continue this QEI dialogue with many other episodes in the future. Your participation and contribution to this will always make the difference that we want to make. Thank you.